Okay, welcome everybody. Welcome back to those of you who were here for a very interesting session this morning on ethical advice in the pandemic. And also welcome to anybody joining us just for this afternoon. We arranged the conference in two separate sessions in the hope that those who couldn't spare a whole day could at least attend part of the conference. So I'm Emma Cave, and together with Dave Archard and our wonderful RA, Mariana Ditborn, and the assistance of Olivia Wheeler, we've been looking at ethical advice and ethics committees in the pandemic, primarily through a series of webinars spread over the course of the last year. And this has been funded by the British Academy. We have recently launched a new website. I just wanted to briefly show that to you. It has links to various things, including publications and to the webinars. So we've got webinar recordings, so that there's access to those, and also to a series of blogs. So here are some of the blogs we've got already. We've got a few up there, and you can see sort of Dave and I are a little bit lonely there. So we very much welcome the possibility of blog posts from panelists and attendees if you have something that you'd like to say about ethics committees and ethical advice in the pandemic. Okay, so this morning we considered ethical advice in the pandemic. And we were very lucky to have two fabulous speakers. Jonathan Montgomery set off with a number of tensions in providing pandemic-related ethical advice. So he talked about the time sensitivities, sometimes because a matter is so urgent, but also sometimes because pertinent information isn't yet available and the matter might need to be delayed and debated at a later date. Also the need for a safe space for committees so that they can produce advice, and that can sometimes limit transparency. Sometimes the fixed parameters of the debate, where certain options have been discounted by government, and also the politics of providing ethical advice that will have traction and influence. So a number of factors then that can impact on the ability to comply with principles of good governance that perhaps we would be able to apply with more readily in a non-pandemic situation. We also heard from Dominic Wilkinson, who spoke about the ethical nature of guidance, focusing in particular on triage and lessons for next time we have a pandemic, which of course there will be a next time. He recognised the significant reliance that's been placed on clinical ethics committees in the pandemic, especially early on in the pandemic. And we've seen in our project survey, which Mariana's going to talk about a little bit later, that when national guidance on triage wasn't forthcoming, a significant number of clinical ethics committees produced their own guidance for clinicians. And it's likely that this guidance could have differed from one committee to another, and it certainly must have involved a considerable investment in time right across the country. So the format this afternoon, which those of you who attended this morning will find fairly familiar, is to hear from two speakers. We're going to start off with Dame Suzi Leather, and then we're going to move on to Dr. Jo Brierley. They're each going to talk for around 20 minutes, and what we hope is that you can put into the Q&A function questions that you have for them. After that, we'll have a presentation from Mariana, who is going to look at some of the preliminary findings from our survey, and then we'll end with a panel discussion, some of the themes that have been raised. At that point, Jo and Susi will be joined by Professor Richard Huxtable and some of the panellists from this morning's session who've kind of returned. In particular, we've got Jonathan and Dominic, so very warm welcome back. Now, before I introduce the speakers, I just want to spend a couple of minutes outlining some of the questions that we've encountered in the webinar series, which we're hoping will get further discussion today. So we've had 5 webinars, and most of them have touched at some point on ethics committees and their role, and 2 of them looked in detail at the role of ethics committees. So our first question is, do we need a national ethics committee? We've got a number of ethics committees that give important advice in the pandemic, including the BMA Ethics Committee, the Moral and Ethics Advisory Group, which Jonathan Montgomery co-chairs, and also the Nuffield Council on Bioethics, which produced an influential pandemic-related suite of resources and advice. So we were far from rudderless in the pandemic, but the question remains, would a formal National Ethics Committee have more traction in a pandemic situation? If so, what should its remit be? Who should sit on it? Should it be advisory? Should it be executive? And then the next theme explores the role of local ethics support services. So together with Dave, Joe Brierley and I, we've written about some of the problems that flow from a lack of clarity on clinical ethics committee function. So our second set of questions ask whether clinical ethics committees should be advisory or whether they should, in some situations, make decisions, whether they have a role to play in dispute resolution, whether they should look beyond case consultations to provide guidance, to provide educational activities, and to support people that are experiencing moral distress, clinicians in particular. The next set of questions moves on from the function of clinical ethics committees to look at some of the critical issues that they're facing. I'm not going to say much more on this now because I think we can discuss this theme further once we've discussed the preliminary results of the survey, which Mariana will go through later. Another question goes on to ask how we might ensure a maximally efficient and competent set of local committees. In the webinars, we've touched on the possibility of enhancing access to education and training, and possibly even thinking about licensing or regulation. And then the final theme asks what counts as good ethical advice from ethics committees and how we can go about measuring it. How far do we focus on procedures? How far do we focus on outcomes? And this, of course, connects us back nicely to the theme from this morning. With some of those questions in mind, and I see we've got Joe now. Welcome, Joe. I'm very glad to welcome back two speakers from our webinar series to develop the points that they made there. First up, we will welcome Dame Suzi Leather, who previously chaired the HFEA and the Charity Commission, and who now chairs the Devon Sustainability and Transformation Partnership. So Dame Suzi helped develop a pioneering system ethics committee, bringing together social and healthcare. So very, very good to hear from you, Suzi. So there'll be some time for questions for Dame Suzi's after Dame Suzi's presentation. So please, again, do put them into the Q&A and we can deal with them after her talk. We'll then turn to Dr. Joe Brierley, who's a consultant in paediatric and neonatal intensive care and also Vice Chair of the Great Ormond Street Hospital Clinical Ethics Committee. And then after we've heard from Mariana about the survey, our speakers will be joined by Professor Richard Huxtable, who is Professor of Medical Ethics at the Centre for Ethics in Medicine in Bristol. And he's running an important project on best interests, and he's also recently been appointed the chair of the UK Clinical Ethics Network. So a very warm welcome to Richard. And we're also delighted to welcome back some of our panellists from the first session. Okay, so I'm going to ask Mariana now to share the slides for Suzi and welcome Suzi.
Thank you very much indeed. And let me say at the outset what a huge privilege it is to be here. Fantastic session this morning. And I hope that the experience that we've had in Devon will be of some help, especially in teasing out this, the pros and cons really of having local ethics system level ethics committees versus a national one, and perhaps what might best be done at the different levels. So first of all, next slide, please. What is an ICS? Because I chair the Devon ICS. It's for this purpose, it's not the Intensive Care Society. It's the Integrated Care System for Devon, and we're a partnership between Health England. They're going to be put on a statutory basis in legislation that's going through at the moment. Second reading of the legislation, I think, is tomorrow. A considerable size there and a considerable complexity. So we have 5 trusts, 1 KIC, 3 higher tier local authorities, 8 district councils. We have 5 local care partnerships, 31 primary care networks, 123 GP practices, and more than 500 nursing residential homes. We have 1 collective resource in the Nightingale. Our ethics infrastructure, next slide please, pre-COVID was felt a bit rudimentary really. So either the hospital ethics committees didn't exist or they were dormant. We certainly didn't have a system ethics forum, and there was no mechanism really for debating ethical issues except in acute care settings. So nothing for social care or primary care. Next slide. The impact of COVID on our ethics infrastructure in the Devon system has been quite transformative, really. So we now have a system ethics committee for the whole of the Devon system, Devon Ethical Reference Group, TERG. Each of our hospital trusts have either established or re-established their own ethics committees, and they have representation on the system ethics committee. And in one of our places, Plymouth, they've been quite innovative, and they've established a place-based ethics committee. So that matches the local care partnership in that area. So that at a city level is bringing together local authority settings, so social care, as well as primary care, acute care, mental health and learning disability services. I think that one issue which was perhaps particularly pertinent to the ethical context for COVID in Devon was that although we had rather expected in a way after a few months to have lower levels of COVID than perhaps some of the rest of the country, we felt we were more vulnerable because in terms of critical care capacity, in terms of rurality, in terms of our demography, we were rather worse off than many other areas. So I thought, we thought it was particularly important, especially where we were sharing facilities and sharing staff, which happened, of course, not only since the Nightingale, but pre-Nightingale. Very, very important to be using the same protocols and to have the same ethical approach. Next slide, please. So we felt really quite early on in the first wave that we had to do something. We were seeing what was happening in Italy. We were concerned very much about the impact that was having, of course, on patients and the public, but also on clinicians, treating clinicians. And so we had our first meeting in early April, and we aimed to do these things, to coordinate and give system cover to all of our hospital ethics committees, to be a place where ethics issues in primary care and in the CCG and in social care could be aired and deliberated and advised on. We wanted to fill in any gaps in national guidance or regional guidance. We felt that we would need to respond to requests for advice. We certainly wanted to align our response and establish a common approach. And that was important, essentially to prevent a sense amongst the population that they could be treated differently in different places or to exacerbate any existing inequalities. I think we tried to have a broader spread as possible of the authoritative base in terms of our membership. So we had representation from each organisation, including the ethics committee if there was one. Our group was chaired by myself, so I'm the system independent chair. We had our system medical director on there. We were really, really fortunate in being able to draw on some fantastic external ethical and legal expertise, including people who were on this webinar. So it was great, for instance, to have Richard Huxtable, to have Emily Jackson. That was really, really important for us in giving us confidence in our local deliberations, I think. We had representation from Health Watch, and that person also sits on the Southwest Clinical Senate Citizens Assembly. We had a Director of Public Health. We had our Equality, Diversity and Inclusion lead. We had people with primary health care and social care backgrounds. We had end-of-life expertise. And depending on the subject we were discussing, we brought in other people who we felt would be helpful in terms of posing questions to us and potentially coming up with some solutions. So when we were considering vaccinations, for instance, we had the equalities officer for the vaccination cell, we had a local GP leader, When we were considering ethical issues in care homes, we brought in care home commissioners as well as providers. I think that mixture of the theoretical and the practical was really helpful to our deliberations. So specifically on the ethical expertise we were drawing on, it was quite diverse. As I've said, we had members of our local ethics committees. That was important to bind them in, to give everyone a sense of shared ownership. Some, of course, they were therefore clinical medical people, but one of the chairs of the ethics committee is one of the trust chairs, so we were getting some lay representation as well. And I've said how important I think the external expertise we were able to draw on was, and one of those people, Lord Richard Harries, has a faith background and of course is a member of the Upper House. So this was our overall governance approach to developing our guidance. So we developed a draft document, first of all on the overall ethical framework, and then on the specific situation that we felt was a gap, which is of demand for critical care being greater than supply, and how we would triage. So the draft was then, was it submitted and agreed at system ethics committee level. Then we sent it off for legal advice. The legal advice came back and said we should have public consultation. We revised the documentation in the light of that public engagement, and our guidance was then signed off by each of the statutory organisations. So for the trusts, it was their board; for the local authority, it was their cabinets. So I think that our process was certainly done on the basis of a consensus, non-hierarchical, very consultative methodology. So what have we actually produced? Well, first of all, as I've said, an overall ethical framework, ethical principles and infrastructure. And that the intention was to inform both policies and practices in health and in social care settings. And then secondly, we produced guidance on allocation and withdrawal of organ support. And I can say more about that in questions if anyone is interested. We have discussed and issued advice more widely. So we have also looked at ethical principles, the non-clinical transfers from our trusts into the Nightingale, which is a collective resource. We've looked at ethical issues arising from the mass vaccination programme, the prioritisation in the elective waiting lists, which is a huge issue for all trusts nationally. And we've also looked at ethical issues in relation to visiting in care homes. Next slide, please. In terms of how we went about it, because we talked this morning about the sort of both the fact that there appeared to be quite important gaps in national guidance, but also quite a lot emerging and some guidance that already existed. So we looked at everything that we could find at that stage. So BMA, RCP, NICE, Intensive Care Society. We looked internationally as well. We did the literature searches. I hope we didn't miss anything vital. GMC, obviously. We looked at what was beginning to be drafted elsewhere, including in Oxford and Birmingham, and I had some extremely helpful conversations with relevant experts, including Jonathan Montgomery and Dominic Wilkinson, for which many thanks. And as I've said, we subjected our draft to a QC, and we wanted his advice. It was a him, both on our decision making, but also any procedure that we should go through in order to make our guidance as secure as possible. And we used a QC called David Locke. Next slide, please. On this business about getting a legal opinion, so we started from the BMA approach that legal challenge was unlikely to be upheld so long as decisions had met appropriate legal standards and reasonable collaborative based on good evidence, etc., etc. We felt that those requirements were probably adequately addressed in the ethical framework, but we did feel there were some particular legal issues which we may be more vulnerable on, specifically equalities legislation, the circumstances in which treatment could be withdrawn, and indeed how far our system guidance could be challenged. So those were some of the reasons we went to the QC. I've said that we were advised legally that because there's a legal duty on trusts and public bodies to involve the public in decision-making policies, that the public should be similarly involved in shaping our framework, ethical framework, and the guidance on withdrawal and allocation of critical care. And this was really quite a big issue. Whether and how we would do this was important. We were, I think, extremely lucky in Devon in that we were able to draw on an existing citizens panel. And we convened 3 specific focus groups in addition to sending out written documentation to the citizens panel. We had 3 focus groups. We had one for older people, one for people living with disabilities, and one for BAME communities. And we chose those 3 because we thought that those people might perceive themselves as having a heightened vulnerability either to COVID itself or to clinical decision making about COVID, and particularly in a triage situation. And I think having focus groups to look at our draft guidance was extremely helpful because it allows more discussion than you can have if you simply have please comment on this draft. And here are some of the issues which emerged in that focus group work. So a real concern, particularly from people living with disabilities, but also from BAME communities, about unconscious bias in clinical decision-making. The role of families and carers in decision-making, the need for sensitive and careful interpretation, concern about what would happen with about disagreement, both between clinicians and families and between clinicians. There was also concern about a risk for staff involved in having to make difficult decisions, including emotional damage. And there was some concern about the accessibility of documentation, sometimes about documentation itself. So we needed information in different forms than written. Next slide, please. So in terms of how we sought to protect our frontline staff, which was one of our real concerns, reflecting on what was happening in Italy. Firstly was raising ethics to the boardroom. And as I've said, that was not completely novel, but got considerably greater focus, I think, through COVID. Our second real concern was how to coordinate across, and the need to coordinate across organisations. And we felt that if we had legal advice, both our boards and our treating clinicians would get greater reassurance about the content of the guidance, as well as the process that we'd gone through in drawing it up. Next slide, please. The issue about moral distress and injury, what was a really strong motivating factor, and how COVID is impacting on frontline staff, both in primary care and social care as well, is something that we've given a lot of thought to. Importantly, it was this issue of moral distress and injury was also viewed as important by our public consultees. So I think the protection we were, the nature of the protection we were hoping to provide was protection through recognition that they were potentially in really difficult situations. Protection through the separation of responsibilities. So we suggested that wherever possible, a triage decision should be taken by clinicians, not just clinicians who have the responsibility for treating their particular patients. Protection through governance support, through the provision of counselling, and the possibility of escalating both within hospital to ethics committees and from those ethics committees to the system one. So a real increase in the shared deliberative capacity within the system. Next slide, please. Lastly, on lessons, really. So it certainly felt to us that there was a really significant vacuum at national level on a hugely important issue, namely critical care triage. I think that our experience in Devon has shown that it is possible to formulate ethical guidelines and guidance at a system level, and that the consistency is important and was appreciated. I think the fact that we did this at a system level went away to cementing our system governance and approach in other ways, actually. And I think certainly systems are being required to have a collective approach to commissioning, to workforce planning, and sometimes deployment, to capital and investment planning, to infrastructure. So why on earth not to ethics as well? Something that was mentioned this morning was the importance of doing the difficult deliberation in advance of the pandemic. And I would completely agree with that. It was really helpful that we had some time at the beginning of the COVID first wave. We weren't hit as early as some of the other systems, and that gave us a bit more time, but I think it would have felt extremely difficult if you've been trying to do that, produce that guidance in areas which were very, very hard hit by the first wave. We've certainly experienced the benefit of public engagement. In developing the guidance, we did amend our draft guidance in the light of the public engagement. And I think that I'm actually sure that it gave it an increased moral and legal authority. I think if there had been an earlier focus on ethics nationally, that might have forestalled some of the problems like PPE and the allocation of PPE. One of the things difficult to focus on non-secondary care issues. So ethics in social care and primary care are not so well developed, and I don't think it's just in our system. I think it's a national issue. The public engagement that we did certainly revealed other issues that we've actually taken on and done some more work on. So the very strong concern about unconscious bias in medical treatment is something we've subsequently done work on, particularly with our BAME communities. And I think that it was an important trigger for that further work, looking at the experiences of BAME staff and BAME patients as users of services in Devon. I think that's probably all I want to say at this stage. My next slide just briefly sets out the relationship between, so we are there as the system ethics committee in the middle with our local ethical infrastructures on the right-hand side. And we do have a Southwest, or at times we've had a Southwest ethics group. It's come and gone a bit because of pressures on individual people during COVID. And there's not meant to be a hierarchical relationship between these three levels. They are all advisory. Okay, that's all from me.
Thank you very much, Susie. If you'd like to stop sharing, brilliant, you've done it already. So thanks so much, a really enlightening talk and some fascinating good practice features there, I think, come to light, such as the way you opted experts to balance the local, the ethical, the subject matter representation, your consultative process, the public engagement. The legal advice was interesting to me because I've come across other ethics committees that have done a similar thing, and I'd imagine that may well have enhanced trust and confidence in the guidance. But I also think a feature that perhaps you didn't talk so much about, but I think your openness about the process that you went through must have been a very valuable resource for others who were setting up services. So thank you very much for that. Now, we don't have any questions in the Q&A as such as yet. So please, if you're formulating questions, keep working on those, and just perhaps make clear in the Q&A that your question is for Susie rather than for Joe, who's coming up next. And then we'll come to them after Joe's presentation. But we do have a question from Richard Huxtable. So I wonder, Richard, if it's just easier if you just say it rather than me reading it out. Thanks.
Yeah, sure. Thanks very much. Thanks, Susie. And I should obviously, you did say it very explicitly, but I should say again, I'm asking this question outside of my role on the group itself. So I'm just wondering if you know how the work of DIRG, of the Devon group, has been received on the ground. I'm thinking perhaps particularly by professionals or practitioners, but also by public patient service users. Any indication whether it's been well received?
Well, it's quite. So I had a conversation a couple of days ago, actually, with one of our trust chairs who had a recent meeting on the ethics committee where many of the clinicians were expressing extreme anxiety about the situation they are now in. So, the public think that it's all over, but it really, really isn't. And actually, our system is probably running hotter now than it. I'm not sure at any stage in first wave, but it's beginning to feel very, very uncomfortable. And I said, is the guidance of any use? And he said, oh yes, no, they think it's wonderful. In fact, they brought it and quoted from it, and it really is helpful. And that gave me some comfort, actually, because I heard one of the things that was said this morning about the sort of comparative uselessness of guidance, which is based on capacity to benefit. And our allocation withdrawal guidance is based on capacity to benefit. But obviously it's a little bit more nuanced than that, and frailty is clearly a dimension of that. But it's obviously helping people enormously. And I think it's not only because there's a document they can read, but they know that it was subject to wider discussion and that particularly vulnerable groups had a chance to input into it. And I think that really has made a difference. In terms of public and patients, I think they are probably particularly pleased that we've gone further and looked at BAME communities and staff current experiences. So I think that's been of unconscious bias. I think that's been important.
Okay, thank you. Thanks for the question, Richard. So we do have a question in the Q&A now, which is that Jane Harris says that the trust she works for has a system of flow with other services in the local area. And she wonders whether the system-based ethics approach might work in other contexts. If you can just give some advice about how you think that model might be replicated in other contexts.
So it was. So if I just think of some of the other things we've looked at, for instance, GP practices have come under increasing pressure from people wanting vaccination outside the JCVI guidance. And in fact, some of our practices, more than 50% of calls into practices was about accessing vaccination outside the guidance. And that was extremely difficult for GPs and for receptionists to deal with. So we recommended that there was a system process. We decided that when applying the discretion that the JCVI guidance gives to on vaccinations, the issue of equivalent clinical risk was very relevant. But that decision should be taken by a system group within the CCG, not by individual general practices or individual GPs. So that's, I think, a good example of, within primary care, of why a system ethics committee came up with a system solution.
Fabulous. Thank you very much. So I think we'll now move on to Joe's presentation. Joe, do you have any slides to share?
Yes, ma'am.
That's marvellous. I did give a very formal introduction of you, but I wasn't sure if you were available, if you were here at the time. But
the only formal thing, Emma, the only formal thing is I'm on the shores of Loch Ness, so when my internet goes wonky, just let me know.
Will do. Thank you very much.
Hello, everybody. Thanks again. Amazing to be asked to do this. I'm going to talk a bit about ethics support that we developed in our hospital, which is a tertiary children's hospital in London, and then a bit about how that was adapted for the pandemic and thoughts about where we go from here. I apologize for missing this morning, but I was on a boat on my holidays in Loch Ness, which was great fun. Didn't see any monsters, though. I was very disappointed. I thought that was a guaranteed thing here, but there we go. So, I mean, reflecting about ethics and ethics support over years, I think we're still stuck with major fundamental questions about what it is. Is it decision support, moral guidance, moral mediation, we've talked about sometimes? And then the question that's a really thorny one about whether ethics groups, whatever they are, have a role in clinical decision making, which obviously is lawfully problematic, but something many clinicians have been kind of requesting repeatedly over the years, and indeed families increasingly having similar comments. Who is ethics support for? The old traditional model of being for doctors, much more for clinical teams now, but should it be for the patients themselves? And there's a real story behind that. Who should provide it? An old kind of a kind of across the pond approach of a single ethicist on staff, or a grand wizard. My colleague Vic Larcher used to call them, and I was really disappointed when I met some US ethicists and none of them looked like Gandalf. I was very upset. But should it be CSCs, CCs, as we have in the UK, and what should be their constitution? And then finally, crucially, who should attend these meetings where we talk about the moral aspects of a clinical situation? Referring consultants, the clinical team. Who amongst us brings community teams and GPs in routinely? Patient and family, should they be part of this? Faith, other representation, and lawyers. We've had families who've wanted to bring lawyers. We also have lawyers involved as part of our ethics team, which I'll come on to. So very interesting, that kind of an old-fashioned jibe at ethics committees about being some sort of quasi-judicial process. Still there's a penetration about that in society. So here we go, pre-COVID, the Great Ormond Street ethics story. It has sometimes felt like this. I'm yet to meet Mount Doom, but a saga. Until 2012, we really had a traditional ethics committee model. Being a children's hospital, lots of paediatricians, social worker, intensivists, anaesthetists, moral philosopher, we were very lucky to have back in the day. A single nurse, which is interesting. A GP from the community, which was incredibly helpful, trying to keep us grounded for reasons I will again come on to. And the previous parent of a child in the hospital who'd been through complex care, that was very, very useful. And a children's author, our left field approach, which was unbelievably helpful. Ellie Nocti, thinking about complex ethical issues. The group largely discussed themes and cases, but met once a month. If you brought something to the ethics committee the week before a meeting that was busy, you had to wait 6 weeks to discuss your clinical matters. And I don't know about other clinicians on this webinar, but waiting 6 weeks for a clinical decision that you think is ethically problematic is a very long time. Very rarely parents did attend. But the one I remember particularly was about a young man who came and thought he had to make a kind of a 12 Angry Man pleading for his child's treatment, which is very, unsatisfactory. It didn't feel very well for anybody involved, including him. He felt that was the normal process, and thinking about it that way almost addressed us as my lords and ladies. It was very strange. So I think we've developed our parent involvement and done reasonably well, but more about that again as we go through this. But it was very uncomfortable at that stage. And there was just the occasional ethics facilitated MDT for patient care in the hospital, but most of it was in the boardroom on a Wednesday evening once a month. I just want to remind people who don't look after children all the time, there's a couple of things that push our change in how we think about ethics. And one is, on the left, I've just spent a good couple of months looking after adults for the first time in my career since the mid-90s. I'm told the GMC won't frown too badly at me because I was trying hard, but I know who the patient is. It's the bloke in the bed. On the right, we very much treat the family. The parents are our consenting people, the best arbiters of a child's best interests. I won't spend many hours going through that, but generally that's how we work, and that works very well normally. The other thing that's important about clinical ethics, if it's involved decision-making, the thing about decision-making is I don't think we've really even discussed that very well in terms of how our national standards exist. Here's the NHS document, and it suggests clinicians bring treatment options, the patient brings their beliefs, lifestyle, and values. Well, I think that's fundamentally flawed, because clinicians have values, they have belief systems, and whether that's the medical orthodoxy, hospital echo chamber, a faith in the hospital system, you could pitch it as such, or cognitive biases about clinicians' decision making, that might be true. But again, I think there's a fascinating bit of work done by the adult intensive care guys in Europe that showed whether you have CPR at the end of life throughout Europe depends on the adult ICU's consultant's religion as an independent variable. So the idea clinicians do not bring value systems to decision making is fundamentally flawed. And of course, patient brings facts too. So I think that's a real problem. So we moved our ethics committee on a little bit with our huge support from our executive team, actually. And we really increased the multidisciplinary component of the ethics committee. Many more nurses and allied health professionals came on board, because guess what? People who work shifts can't get to Monday meetings once a month. So that was really important how we changed things. We increased having more ethicists to support our moral philosopher, who may be on this call as we speak. Faith leaders, social workers, psychologists, a lawyer, retired High Court judge. Previous parents increased, but also we had associate members, people who come along and learn to be part of the committee. So with teaching and training before you become part of the group. And a deliberate increase in BME members was our initial approach to trying to improve something that was problematic. We certainly go out to children now in the hospital. Most of our engagements is what we call rapid responses, 20 to 30 of those annually, with parents and children usually, but not always attending. I'm sure we'll talk about that later on. Education, training, supervision, staff drop-ins. We've been trying to combat moral injury using ethics for about 5 or 6 years now. It's very well received and the feedback is very good. More than that, one of the great questions about clinical ethics is how effective is it? We started to get feedback, but efficacy is probably a tough bar. And research with peer-reviewed publications and an annual report. So to the pandemic. So we were reasonably set up, we thought. Again, our committee had been involved in discussions about the H1N1 pandemic. And I have to say, there were far more ethical discussions and documents set up in advance for that pandemic than for this one. The Ebola pandemic, again, we'd done some work with the Department of Health being part of the decision-making group there. Warning organisation, weekly Zooms, London Bioethics group we set up, really trying to think through what would happen if we were overwhelmed with children, trying to think about how we would support the children's centres. Hot activity, I'll go through a little bit very quickly, case reviews, education, research, staff support, and then really strong thoughts about recovery from the pandemic and what we do. I think there is a big ethics component to that, which children's ethics committees, paediatric ethics committees, all ethics committees have an important role in. But here we go. Here's our wonderful bit of clarion call before things happened. The summer before, we submitted this to Lancet Respiratory saying, we're not ready for a pandemic. And actually, because this pandemic has not affected children badly, and I don't mean not thinking about long COVID and some of the unfortunate social aspects of this, but very few children became critically unwell. We are sitting ducks for another pandemic that does affect children, because we have so many things we have not thought through. Many children are living immunosuppressed on organ support at home in their bedrooms, ventilators, renal replacement. And those children did not exist 10 years ago, certainly not 20 years ago. So we have much ethical thinking to do about supporting children in that situation if a pandemic that does affect children, such as a flu pandemic, hits us. This is all available on the previous pandemic talk I did for this webcast, so I won't labor it. But we did a lot of work on organizational readiness. As Susie said, we prepared lots of documents to support people. We did that as a regional thing in terms of the London region with other children's centres, talked to our Italian colleagues, tried to work out what was coming, and thought about decision support by the bedside. And actually, because we are a standalone children's hospital, we had far fewer ethical requests about acute rationing. Some of the people in our group who look after adult centres as well had an awful lot more support in that direction. In terms of the ethics. We did have case reviews, a lot about whether to use innovative therapies, a bit about prioritization and trying to think about some of the things our hospital usually did, such as stem cell treatment, gene therapies for children from overseas. When the UK was in lockdown, could children come in and have these treatments that we were one of only 2 centres in the world to do, when they would die without those treatments, but there was a major problem with international travel? And what did that look like for the hospital in terms of having people come in for rare disease treatment when other people might have been dying from lack of ventilators just down the road in adult ICUs? Lots to think about there. And we had a new disease emerge in children. You may recall this during this process, the entire pandemic, a post-inflammatory condition, PIMS-TS, for which emerging treatments were thought about. That was very, very interesting, seeing a new disease pitch up, as well as COVID-19, a post-inflammatory condition. And then other hot topics, education of staff support. My colleague Ag McNiven did a lot of work together with UKCEN and other colleagues thinking about moral injury prevention sessions, and certainly thinking about that for redeployed staff to adult centres, people who'd seen lots of deaths in very difficult situations in adult ICUs. Being in London, we were probably the first and hardest hit of the UK regional areas, and lots of difficult stuff happened, that's for sure. Recovery, we really thought long and hard about this, and we engaged with 2 groups, the children in our hospital, so our patient groups, and we ran a webinar with them and even published the outcomes of that about their thoughts about the role of children in the pandemic, and they were terrific. And then we actually did a webinar on faith groups and no faith groups, with the people not representing faith but patient support in there, and again thought about that in terms of religion and the role of that in recovery of our society from the pandemic. And I do think we haven't done very well in that at all at the moment. That's a broader theme. And then last, I think one of the roles we have as an ethics group is bioethical advocacy, and for us, children's issues. And we know the effects on children. They've not particularly been with horrible COVID infections making them very sick, although that sadly has occurred in a number of situations. But the psychosocial effects of lockdown on children, education, university, mental health, we've seen a massive, massive rise in eating disorders in children, possibly linked to what they've seen in the society going on. Domestic child abuse have increased, poverty recession follows the pandemic, of course, and delayed presentations, fear of their parents bringing them into hospital, was a big thing as well. Done work in all those areas. Vaccination, of course, is a massive question. The major group not vaccinated currently in our society, children. Should they have vaccinations versus giving vaccines to countries where people are still dying of acute COVID? An interesting question. But there are lots of children who are suffering from long COVID, particularly older teenagers. So it's a really, really difficult question, I think. And I do not envy the JCVI with their recommendations to government. Delayed ops chemotherapy transplants are all there. Child issue, particularly, children do badly after a crisis. After every crisis in society, children's funding gets pulled back. And again, we push very hard. And again, women's funding has been pulled back horribly too. The 2 groups where money has been pulled out of medical care and social care. And we've thought a bit about that. Local CECs in a pandemic. Well, I think the key thing is bedside support. Susie documented this beautifully and set up things very well. I envy huge amounts of what they did, but I still think the basic by the bedside support to clinicians and families is the best role we have. The slight problem is we can be rapid and reactive, but ethics committees are not powered to consider subtle or overt rationing in an ICU, particularly if they're not present all the time. And this is a real challenge. They're not a lawful decision-making body. So for that to be suggested is a real problem, and I think we really have to think long and hard about that. Decision support is certainly where we pitch our activity at the moment. Any change in that, I think, is really problematic. Consistency of ethics committees is, I would say, almost unknown, but unlikely to be very, very strong, of review, of process, of the outcomes. But is this better or worse than having no ethics? And I'll hasten to remind you of the previous policy in the H1N1 influenza pandemic, but also in the COVID in some centres, where three wise men, always seems to be men, Emma, never a good thing, I would argue, make these decisions about people without the people being involved themselves. And I certainly experienced the three wise men approach in the adult intensive care I worked in, but there was far more engagement with families there than suggested in the comments I've just made. But I don't think they were pervasive. I think there were certainly other situations in which limited family engagement occurred during the pandemic, both in ICUs and outside ICUs, about some very important decision making. We also were very involved, as Susie mentioned earlier, about institutional executive support, particularly visiting policies, which I have to say people found really tough. And I think particularly in a children's hospital, where naturally children are assumed to be in the presence and supported by their parents. Indeed, many of us have led campaigns about having more access of parents to very sick children in hospital, even for the 1950s and 60s, which, unlike Dave, I don't remember. Do I get away with that, Emma? I carry on, just ignore it. Okay. So the other thing is prioritization. And we were involved with some of this in terms of, when do you do bone marrow transplants for rare disease, given the risk of that, the risk of requiring an ICU bed when there aren't any ICU beds available, but a patient has no other option. So several of those were part of our work. Document standards, yes, the local regional guidance we provided was very well received, but fortunately was very little used in terms of children. National guidance, I think others have commented already, but I think there was a huge lacuna of support and guidance there. We have had great discussions since then about whether national guidance in ethics is actually a thing, whether it should be a thing, or these things need to be devolved and more regionally discussed. Educational stuff was important, engagement, particularly for staff, I think, early on about pandemics and what may need to happen. And we certainly, for our public, had sessions with the children's groups in the hospital. Research and audit I've touched on. The other key thing was staff support. And this is for people who are facing rapid existential decision-making, whether they were nurses, medical students, AHPs by the bedside. This is something we had never come across before. I think just supporting people that they were doing the best they could and really trying to talk through some of the things that were worrying them. We've had feedback that was really helpful. It's really hard to get really better data than that. I think advocacy was important. Disadvantaged groups. We had the children with disabilities groups really worried that their children weren't going to be allowed into intensive care units. And we reassured them there was no change in the law at this time. But, we also have to leave out that may need to be something that's discussed in the future. And that's something that I think, as we heard earlier, must be discussed before a pandemic comes. We can't wait for a crisis to come and we have no beds left. And Dominic did some really good work about this. And I think the questions there are huge and not resolved yet. The other thing that was very interesting for us, there was national guidance coming out about CPR saying you should not do any ventilation. It should be entirely cardiac resuscitation, bouncing on the heart, which is completely hopeless if you're a baby having had an arrest, because children die of hypoxic arrests, very rarely from primary arrhythmic stuff. So trying to push for CPR guidance not to be harmful for children was one of my early memories of the pandemic. So where now, to finish off? Well, the problem with ethics committees as they stand, I would argue there is no established governance. We've seen random new committees set up. Some are regional, some are in individual hospitals, but the Caldecott principle is very clear. There should be minimal necessary data sharing. And how does that work when you're sharing with regional groups? I'm not sure. I don't know the answer to this. Do we really want to have some quasi-judicial body such as the Ontario setup, where decisions are devolved from the courts to some regional ethics group with a judge or a lawyer as part of it, but they have decision-making capacity over a clinical situation? If that is the case, then CECs are clearly not fit for that purpose. Are they fit for their current purpose? And what is that purpose? I go back to my initial discussions about what clinical ethics is for. And as someone very, very involved with this, there are still many questions I have. The reproducibility of work between committees, I think, is a key problem here that we haven't really begun to discuss and haven't been involved with the research ethics committees. That is really in its infancy in those bodies as well, where you may argue it would be even easier to have the same decision made about whether a research piece of work is suitable for submitting the public to than for end-of-life decision making. These are all existential threats despite the current COVID boost to ethics committees. I think they need professionalization. A statutory role, standards and processes like research ethics committees, well, with that would come regulation and funding. And I would say, bring it on. I think both of those would be very, very helpful. An audit of efficacy and process to work out what we're doing would be very helpful. And I can't leave without talking about a recent judicial criticism we had of our committee about parent and patient involvement and indeed attendance, which I think they slightly confused in ethics meetings. And this was from the only committee, according to UKCEN, meeting in 17, a recent survey, who routinely involves patients, not all the time, but most times in ethics groups. And I know other committees I've talked with since have debated this, and most have decided to remain really often not having patients and parents involved in our context with children, or to have this as an ad hoc decision at most. So lots to be discussed there. Each specialist CECs like research ethics committees. If we have professionalization, will we have pediatric committees, rare disease clinical ethics support groups? Our reviews are 50% about innovative therapy, completely different than most other ethics groups. Certainly the integrated community social care stuff, the paradigm from the Devon group about this is brilliant. But public consultation is fascinating. Should this be national, local? For specialist centres, who is our public? We don't have a regional group round us. Would we go to children's groups? It's really interesting and to be determined. We've got a paper that's hopefully just about accepted into clinical ethics. Before the pandemic, to pull you back to that time, that halcyon time, and we went around our district generals and had workshops and interviewed staff there, UK PICUs and the children's hospitals in London, just to compare ethics support before the pandemic. And none of our district general hospitals had ethics support. Simple statement, didn't exist, apart from we ask a colleague who's interested in some of the ethics stuff, or we talk to the legal team when we can find them. Some people didn't know they had a legal team in hospitals, and this is talking to clinicians and nurses by the bedside. 24 out of 28 PICUs nationally have ethics support available, so that's children's ICUs, and we use that as a proxy for UK tertiary paediatrics, where about half of all ethical dilemmas seem to come from when you read the journals. So no surprise. 5 out of the 6 London children's hospitals had centres had ethics support as well. When we asked people what they wanted, most district general hospital teams didn't want an ethics committee, thank you very much. They were more happy to deal with this in a shared care way, where most of their complex dilemmas were shared care oncology with tertiary centres, but they would like more involvement of the children when they got into complex situations in tertiary centres. And that was even when they had a standalone NICU. They really felt the ethics stuff should be pushed to the tertiary centres. Despite us saying, look, we could provide this, what do you think? They were very clear that's what they felt ought to happen. All centres, tertiary, paediatric ICU, children's centres, DGHs, wanted more ethics education and the governance of ethics processes improving. Well, I'll leave you with a final picture there for those of a certain age. We do think our model works, but then we would say that, wouldn't we? I'll let you come back to that quote later. Our referrer and parent feedback is overwhelmingly positive about our ethics team setup, with a couple of very striking exceptions, not all of whom are parents, I would argue, but 1 or 2 people in the 8-10 years we've been doing this have said, no, don't like it, don't see it's helpful. I think we need an external review body for ethics and ethics processes. UKCEN against the core competencies. Well, Richard, you're on the call. I'm about to approach you and offer you some money to come and review us. I know Richard's very keen to get some money. So we think we'd like to be the paradigm group for an external review of ethics processes, because who knows if we're doing harm, good, we have no idea. And our exec team are quite keen to start to develop this. So I think that might be helpful. So I'll talk to you offline. But again, are UKCEN the right group? I mentioned the CQC had reviewed what we do in ethics before. and were supportive, ought they be the right people to review the things? I don't know. So farewell and question time from me, Emma. I'm done. I'll leave you with this miserable picture.
Thanks very much, Joe. That was just fabulous. Really, really good to get the perspective from in relation to children. Now we've got a question from Richard straight up, and given that there was
show me the money.
Yeah, absolutely. So Richard, did you just want to just say your question out loud rather than read it out?
Yeah, absolutely. I look forward to having that chat, Joe. Taking the UCAN hat off, and I should say most of what I'll say today will be very much in a personal capacity. I should just add that disclaimer, but I'm just mindful, and certainly as someone who's looked into it myself with an academic hat on, we've got these different models. You've got quite generalist services. You've got, if we follow your phrasing a moment ago, yours is quite a specialist service, peds-centered, critical care focused, perhaps majority innovative therapy. So it's got a series of cases within a particular box, if you like. Do you think there are differences or similarities? Is your model, having evolved over the last 10 years, one that could be deployed elsewhere, or would things have to change for, let's say, a lot of these are very generalist services, so it might be dementia care, pediatric care, and so on and so forth?
So I think the model itself, in terms of rapid support to the bedside for clinicians with an issue with a patient, I think that would work. I think having education training works. So that model with the 4 things works. I think the moral injury stuff is pervasive. I think, some of the worst moral injury, my sister works in a care home, so I've got iron in the fire, if you like. Some of the stuff the guys there faced is far worse than anything I've seen in 20 years of doing ICU. I kid you not. It was extremely difficult. So I think moral injury is pervasive, and I think support for that could go across all the things. So we're left with research, the one area where it might be that not everybody feels the need to participate in research as an entity, but also maybe they do. Maybe we can think about that. I mean, some of the best abstracts I think I've seen at UKCEN are often from medical students who've been doing a bit of work in the community, and they ask questions that are really pertinent and good. And our group, it's interesting, very few of our ethics questions are from the ICU, but I think in many normal hospitals, I might say, quite a few of the questions might be from adult ICU. So yeah, I think the model possibly would work. The one thing I haven't said is that we have funding. I think that's really important. So we have, I think it's the equivalent of 3 PAs, one of which I get, one to Sarah, my colleague does rapid reviews, one to Anne, who does the moral injury stuff. And we also have a funded administrator. That was our first major step forward. Now, that the first step doesn't have to cost an awful lot of money, but as busy clinicians, I think that's the crucial one. All the other stuff we could do without funding. I think it wouldn't be quite as good, it wouldn't be quite as reactive. But the administrator, to me, I would say, if I had a magic wand, I could do one thing to help ethics groups, it would be that everyone had an administrator.
Okay, fabulous, thank you. Now, I'm sure that other people in the panel have questions, but I wonder if we might just hold fire on those, and Mariana give her presentation on what we've learned so far, the preliminary results of a survey that we've undertaken, and then perhaps we can put all these together. Are you all right to hang on with us for a bit, Joe? Brilliant. Okay, so Mariana, when you're ready, you go ahead.
Thank you, Emma. And actually, I think this presentation goes very well after the 2 other presentations. It will complement what they have discussed. There. So, as Emma mentioned, as part of this British Academy funded project, we did an ethics and online survey to explore the ethics support services during the COVID pandemic in the UK. So we knew when we started doing this project that there was an anecdotal evidence of an increase in number of clinical ethics support services in response to the pandemic. But as you have mentioned many times, there was no definitive register of the number or constitution and other features of those services. And also it was advised early in the pandemic that employees should provide their clinical staff with clinical ethics support to avoid unfair decision-making and, as you have mentioned as well, moral distress. Regarding clinical ethics support services, there was literature previously that said that in 2001, there were 20 clinical ethics committees, according to Anne Slaughter publication. Then in 2010, there were 82 services registered. And then when we last checked last week, the UKCNN website, there were 43 committees and groups listed in the UKCNN website. So numbers have been changing, and we wanted to know what's going on in response to the pandemic. And most importantly, as you have discussed too, is that there is a lack of formal and binding guidance on how these services are constituted, their processes, remits, and responsibilities. So what we wanted to do is to describe the availability, characteristics, and role of clinical ethics support services in the UK prior and during the pandemic. We did this by a descriptive cross-sectional online survey that we developed ourselves and pre-piloted with CEC members and non-members. And in order to reach out to the greatest number of potential participants, we sent the invitation via 3 channels. With the support of the UKCNN, they sent out the invitation through the mailing list. Where available, we contacted directly those who we know were involved in clinical ethics support services. And we also sent out an email to every NHS trust in England, Wales, Scotland, and Northern Ireland, to their institutional emails, asking, please forward this to the relevant person within your institution if there is one. The survey was open between October 2020 and June 2021. We had ethical approval, and responses were voluntarily and anonymous. We knew that time constraints were likely to pose some limitations to our survey. We knew that those that were more likely to respond, participate in the survey, were overwhelmed with clinical and ethical duties, and also that we had to start the survey as soon as possible because some newly established clinical ethics committees may be dismantled after the pandemic. And at that point, we didn't know for how long the pandemic will go on. So what did we get? We get overall 53 responses, of which half of them had an established clinical ethics support service prior to the pandemic, and the other half did not have an established service. Of those that did not have, 19 set up one in response to the pandemic, which means that there was a group, in this case 8, that still didn't have any kind of support, neither in response to the pandemic. In the subsequent questions, we had to eliminate 13 responses because they were substantially incomplete. So from now on, I will present responses from 40 complete responses that were included in analysis. And from those 40, 21 were established prior to the pandemic, and 19 were established in response to the pandemic. So where were they located? Mostly in England, but we had representation from Northern Ireland, Scotland, and Wales. Patient population they served, mostly mixed, also only children and adults. And those that were established previous to the pandemic, most of them, 19 out of 29, function as clinical ethics committees, and one reported functioning as ethics consultant. Interesting, and as Joe mentioned in his presentation, most of the services that were established prior to the pandemic showed a great capacity to adapt and respond to the pandemic context. By different means, I won't read each of these, but they either increase their frequency, they offer 24/7 rapid access services, urgent meetings. So they were able to adapt and respond to the changes. And interestingly, those that were established in response to the pandemic, 17 reported that they function as CECs. But most interestingly, there were 4 that were that they mention that they name themselves with different names as Ethics Advisory Group, Advice and Support Group, Clinical Ethics Forums, Ethical Decision Advisory Group. And we wonder, in relation to what you have been discussing before, if this change in the name is to make clear that the role is an advisory role and to adjust expectations that it's not a clinical decision-making body. It might be, we wonder if this is the case. Regarding membership, overall, from the 39 responses we included here, the overall membership ranged from 7 to 33, and all of them had doctors, and most of them had AHP and nurses. Trust managers were also present, and interestingly, faith leaders and lay members seemed that our data indicates that there seemed to be a decrease in the representation in clinical ethics support services compared to Anslaughter's report in 2011. So faith leaders from 84 to 49 in our case, and 72 to 36 in this survey. Also interestingly, regarding faith leaders, there was a wide range of different religions represented, and most respondents clarified that although they may hold a particular religious view, they were not representing a particular religious view, but offering spiritual faith-related support. This graph may look a bit complicated, but if I explain, it's helpful. The green columns are those services that were established prior to the pandemic, and the orange columns are those that were established in response to the pandemic. The blue ones is the overall membership. And if we compare the membership categories between the previously established and the newly established, we can see that there is no great difference, except from maybe, this is indicative, AHP and faith leaders, which is interesting because we could think that these newly established services were not public health oriented services, but clinical ethics oriented. Here, the kind of ethics support that has been offered during the pandemic, most importantly, ethics discussion via telephone, ethics meeting face-to-face or video conference after the referral, and remarkably, ethics guidance documents, both prior and during the pandemic and in response to the pandemic. Now here, don't be scared for the graph. I will explain as well. Here are the same forms of ethics support, and the first column goes for the ones that were established in response to the pandemic, and the second column for the ones that were established previous to the pandemic. And which is interesting is that we can see that from those that were established in response to the pandemic, they referred that they were offering some kind of maybe informal ethics support before even being established as a clinical ethics support services. We don't know, we don't have enough data to fully interpret this, but we should explore further what does this mean. And also, as I mentioned before, the ethics meeting face-to-face was something that the newly established were providing in great majority. And here, similarly to the other, moral distress support seemed to be provided by a few before the pandemic in an informal setup. And again, just to reinforce the idea, ethics guidance documents is something that the newly established, for example, had 17 out of 19 did develop. Now, and this goes in relation to Joe's presentation, the involvement of parents, patients, and family members. And here we have only previous and or during the pandemic or never. And we provide the participants with several statements. Remarkably, only 4, reported that there is no kind of involvement, either invited to attend or informed of the meeting. However, over 40 and over 60% informed somehow about the meeting, either about the meeting taking place or the great majority about the meeting outcome. This is important because we can see that the active involvement in the discussion itself, being invited to some sort of participation in the meetings themselves, is very infrequent. As we mentioned, most of them developed ethical guidance. Some of them had to develop also term of references. So this, as Emma mentioned before, may a national ethical guidance might help to avoid so many local guidance production. It's also a question. And finally, about resources, we can see that Joe, for your happiness, 80% over 80% mentioned that they did have some kind of admin support. However, we didn't ask what kind of support, and we know by at least Anne Slaughter's previous survey that this can range from 1 hour to part-time assistance. So it's quite broad, this question. And ethics training was 50%, so which is also in relation to the results of the study you showed. So we can't draw any conclusions yet. These are preliminary results, but we can see that there was an expansion of clinical ethics support services. However, there are still groups that didn't have any kind of support. The previously established clinical ethics support services showed capacity to adapt. And as I asked before, may the lack of national guidance have had an impact in the higher level of local ethical documents production? And interestingly, data suggests that there was some sort of informal ethics support offered prior to the pandemic. That's it.
Well done, Mariana. Thank you very much. That was really, really interesting. So they are preliminary results. There's a lot more analysis for us to do there, but we thought it would be valuable to share some of those preliminary results with you in case you have useful questions that might help us in our directions going forward. So we don't have any questions in the Q&A as yet. So I'd like to turn now to our panel members to see if you have any questions. And Jonathan, your hand is up, so please go ahead.
Thanks, Emma. I just wanted to ask both Susie and Joe about what seemed to be a fundamental difference in their approach. And I don't know how much Susie will remember the detail of the document. There's a part of your document, Susie, which says that wherever possible, you should create a separate triage team intended to enhance objectivity, avoid conflicts of commitment, minimize moral distress, and clinicians providing treatment. And that feels as though it's derived from transplant ethics, where in order to promote public trust in the fact that people were not being harvested for organ separation in the transplant team and the treating clinicians, just to reassure people that everything was objective. And that seems to be pretty much diametrically opposed to what Joe described about supporting the frontline traditions taking their own decisions. And the particular thing I'm interested in is the moral distress question, because the claim made, if you like, in that bit of drafting is that we'll reduce moral distress if we take the burden away from people by creating an independent decision maker. And I think, Joe, you probably indicated the experience of almost the opposite, that the moral distress was created by the sort of alienation problem, and then supporting people would be better. And I just wondered what we knew about the impact of these sorts of guidelines on moral distress, because it seems to me that there are perfectly reasonable reasons to think it could go either way, and it would be fantastic to know a little bit more. So I don't know whether we know any about that, but it did strike me as a fundamentally different philosophy that is in those two documents. Thank you.
Shall I come in?
Go ahead. Thank you.
Yeah. So, I mean, Jonathan, I think that's a really good point. From memory, I think we got it from American pandemic guidance, not from transplant guidance. And I hold my hand up. I guess I made an assumption that was, that there was an evidence base for that. Certainly in the informal conversations I've had locally, it suggests that yes, people do find it helpful, that actually it's shared. It's not a completely different team, but there are some people involved who aren't having to deal with patients or relatives and carers, which perhaps brings more objectivity to it. But this is something that we ought to be evidence-based about, and I mean I don't have a sense of what the developing evidence of impact of separating or sharing decision making is. Be really interested to hear it, Joe.
So I'll jump in and maybe not answer Jonathan's question, which is exactly how you do these things. One of the things in the original legal advice for ethics committees in JME 2004, the best way you can stop people referring to ethics committees is to take decision-making capacity away from them. Nothing will stop you getting ethics support than saying to a surgeon, I will tell you whether to operate or not. I mean, it's not going to happen. So I think the clinical relationship is between the treating team and the patient. And the ethics group's role is to probably reinforce, support that. And in some ways, the moral distress of maybe the team having to deliver some sort of treatment they morally might object to or think is the wrong thing should be dealt with in a different way. It's not about making a different decision there. It's about supporting people to understand the broader aspects of the ethical environment they're working in. And that's very much how we have approached things. But I think Suzi's comment, I think it's a comment in Stand on Guard for Thee, I think, Peter Singer's stuff about the previous pandemic decision-making guidance for SARS. I don't think from my colleagues in the United States that ever got enacted. So I'm not aware of anywhere that's set up a different decision-making team to come in and say, you should switch that ventilator off. I think with my clinical hat on, I would find it extremely problematic. I'll stop there. Dominic wants to jump in, I think.
Yeah, I mean, so I think it's in this question about triage decisions and whether they should be separated from the clinical decision makers or whether they should be support of the clinical decision makers. I think it's interesting that there are these diametrically opposed reactions to it. And my impression is that clinicians give Joe's answer, which is, don't you dare get in the way. We know how to make these decisions. If we have to make really difficult ones, we quite like a little bit of support, but otherwise bugger off. Because realistically, we're going to be doing lots of these and you're just not going to be there when we need you. Versus the external view and the ethics view, which is there's an important need for these to be done in a way that's separated from the clinical decision because these are fundamentally different decisions from the normal decisions that are made every day. And this kind of theoretical, I think, often ethicist-driven model, which is that it should be taken by a triage decision maker. But I agree. I've not seen any evidence of the use of that model. I had an interesting kind of debate with some Germans about who were highly critical of this sort of model. They claimed that the pandemic experience showed that this sort of external model wouldn't have worked, but I think there just isn't any evidence of where it has been tried, and maybe that in itself is telling.
Okay, fabulous, thank you. I want to bring in now a question from the Q&A, which is for you, Suzi, and it's in relation to the QC's advice that you sought on your guidance. And the question is it possible that seeking such sort of legal advice about the guidance might change the nature of the guidance so that it becomes less about guiding clinicians in making their own decisions and more about what decisions they ought to make? In other words, that it might make the guidance at least seem legally binding. I wonder if you came across that perception, or if that wasn't particularly relevant given the way the guidance was framed.
I think the main way it changed our guidance was to focus, was to get us to focus more on the process, the governance process we should go through, and the public engagement. That's the main decision. That's the main change it brought. Richard, can you remember anything different that it did to it? I think that was the main thing. I mean, it principally, of course, made the executives within trusts feel safer. That's
Susie and Richard, can you remember what you asked David Locke the question? Because legal advice usually depends on the instructions you've given them. It'd be really interesting to know whether you asked him what he thought, because he's a fairly distinguished ethicist in this area himself. Or did you say, will this get into trouble, or will it breach our obligations? Because it does make a big difference in my experience, what you ask them.
No, it was more the latter. We were concerned to make our guidance as legally secure as possible, and therefore to protect our clinicians.
I mean, it strikes me that, I mean, apart from depending on what exact question you ask, it also depends on which lawyer you ask, because of course, just as if you ask 5 different ethicists, you'll get 10 different answers. Yeah. If you ask, etc. I mean, I thought it sounds like David Locke's answer was extraordinarily helpful, but I would have had exactly the same anxiety. And there is, of course, the tension, because clinical ethics committees typically try to separate what they do from law and say, well, look, we have a function that's different from law. And so that's one of the reasons why we, for example, don't have a lawyer on our clinical ethics committee, so that we separate what we do from legal questions.
Yeah, I think there's a difference between we are a system one. So it's slightly different from the situation of an individual trust clinical ethics committee. We were attempting to come up with guidance which could then be adopted by each of the constituent organisations of the system. That feels, I haven't kind of teased out why it feels different, but it does feel different, and it's already it's another stage removed, isn't it, from the treating clinician. And this was more about assurance for the organisations, I think.
Okay, thanks for that. And Daniel Sokol has said in the Q&A that legal advice is just that, it is just advice, and that David Locke's advice he thinks was made publicly available, which is very interesting. Joe, I just wanted to ask you a question in relation to something that that was mentioned with regards to data sharing in regional groups. So Joe, I think you said that there were difficulties in potentially in sharing data in regional groups. Yeah. I wonder if you and also Susie might say a little bit more about how that actually worked when you were sharing data across the regional group.
Well, our challenge is the Caldecott standard. The minimum number of people should have access to patients' data. Can you anonymize ethics information to the extent that meets that standard? Pretty unlikely, because lots of the diseases we deal with are quite rare. I guess in a pandemic might be more justifiable. I think the problem we dealt with, we for many years have had great fun of having the trust legal team as part of your committee, is as an ethics team don't even have a right, not sure a right's the correct term, but a need, a desire, a duty to see what happens to the patients who we've reviewed. So we're not part of the treating team. So without specific patient consent, we can't even find out what happens at the end of the journey of a patient whose process we have improved, or hopefully, or facilitated, whatever term you want to use. So we've had to now move to getting bespoke consent from the parents or the child themselves, if they're old enough, for ethics follow-up. Into that, you then bring in a regional ethics body that has access to information from someone who's not being treated in the hospital that their governance structure applies to. That's another step. That's quite a big step. And we looked at this when we were trying to set up a regional and national bioethics support system for pediatrics. And one of the issues we talked to people in the family division, and one of the questions is, that minimization of data transference about what is confidential information in order to make you understand an ethics situation that's rich enough to mean you can talk about the nuances, probably does breach information sharing in a standard way. So I don't think we came with an answer, and then COVID came and everyone said, oh, don't worry, we'll just do this stuff anyway. But I do think there's a fundamental question there about data sharing, data information. So our process involves the people on the committee, as few as we can. We've reduced the number who come to ethics reviews. They all have to sign a non-disclaimer when they start the committee, promise to keep things confidential. And unless there's a child protection issue, that's reiterated every time we have an ethics meeting with children and their families. And indeed talk about any clinical situation at all. So I do think there's a lot of work to be done there. And it's one where I do think some very sensible legal guidance would be helpful for ethics committees about process, because at the moment I do worry about the regional setup, the information standards that I think we probably are breaching repeatedly in some of the processes that are ongoing.
But Joe, how is that any different to the kind of national specialist treatment bodies? So for example, some of the oncology, multi-center or national treatment bodies.
Because it's easy. As a clinician, you're involved in the care, and as a secondary clinician, you're giving an opinion on a clinical matter as a clinician. So those bodies are clinically involved in the child's care. It's like we did second opinion guidance based on this. So if you're engaged as a clinician, that is very different than if you're engaged as a moral expert, an ethicist to support decision making, however you want to frame it. It is different. So that's the key
I mean,
thing.
One of the models of clinical ethics is like a specialist opinion. So like a cardiology opinion or a neurology opinion. We provide a clinical ethics opinion. And it doesn't strike me, at least from an ethical point of view. Of course, I mean, there may well be a legal distinction here, but in terms of an ethical point of view, it doesn't strike me that there's any difference to having a regional clinical ethics committee considering a difficult case to having a regional specialist oncology committee considering a case.
So the main argument is, I mean, this was the family division rather than me as an arguing body, but you are not a professional with a governance structure. You have no body to which you are a member that can look at your practice and work out whether you should be, if you're falling below a certain standards. So if you're doing regional stuff in terms of oncology, the GMC is interested in how you conduct yourself, your processes, you're a clinician. If you're an ethicist, I don't know, Richard, I don't think UKCN has struck anyone off yet, but I probably would be nearer than anyone else. But I think the problem there is governance and structure. And maybe one of the things I was asking about is if that could be formalized and we had an appropriate a licensing body, a registration body, whatever you want to say, that might improve things. But at the moment, and this is the legal advice in the family division and indeed our own solicitors, you have no real right to access information about a clinical situation. And that is given to you as part of the clinical ethics group within the institution you're serving, with governance by the trust board. Once you start doing it outside your own institution, I think it's certainly a legal grey area. And I know I'm saying this with people who know much more about the law than I do sitting looking at me. So I'm slightly on a worrying territory for me, but this was on advice from several people. And I think it's an incredibly grey area and clarification would be very useful. But I don't think we can just assume that it's fine because we give opinions on clinical matters. Dominic, you and I both do this anyway. We give opinions on other clinical situations, but you as a neonatologist, me as a pediatric intensivist, and that is very different. And you may argue there's an ethical component to some of the stuff we say in those opinions. I would agree with that. But we are engaged in a very different way than as a clinical ethicist.
So from our point of view, we have never been approached to give advice on individual patient situations. So we're not replacing individual clinical ethics committees, and our concern is with more consistency of policy. Now, the other difference, of course, is that as a system, we're not on a statutory basis yet. So we're not statutory decision makers, but once ICSs are on a statutory basis, this is something we need to to need to reflect on whether that changes the nature of the responsibility of a system ethics committee, because we have not had a legal personality up to now.
Okay, does anybody have anything else? Oh, Joe, go ahead. And then Richard.
Yes, Susie, because that to me, I think is challenging about you becoming decision makers. And that to me has always been a red.
Sorry, no, Joe, I didn't mean ethical decision makers. I mean.
Oh, good. No, clinical decision makers.
I
think that's a red line.
Decision makers.
Yeah.
No. But
it was my misunderstanding.
We are going to have statutory responsibility for the money and performance of the system.
Joe, you'll be able to do what you like, but Susie won't give you any money to do it. So,
so she won't be alone in that, Jonathan, eh?
Richard, go ahead.
Yeah, thank you. I'm going to go back a couple of questions or comments because this is so rich. But in terms of that early discussion we were having a moment ago about the relationship between ethics and law and legal status and the like, I for it to be an ethics service, you do want it to have every available option on the table that's robustly discussed, the rights and wrongs thereof. But at the same time, it's very much a clinical and therefore a practical ethics service. So I'm always reminded of George Annas, I think it was in the US about 20 years ago, commenting that a good ethics committee begins where the law ends. So you still need, I would suggest, some legal input to at least set down some boundaries, even if you think the boundaries are drawn in the wrong place. That's one. The other one is, in relation to the more recent discussion, I'm struck by, well, a couple of things. There are already these questions around not only data sharing, but also questions of liability, in the fact that we know pre-pandemic, and of course since, there are committees set up in X location, but there may be one lacking in neighbouring location Y. And then there has to be a discussion, usually at chief exec or trust board level, about, are we going to send our referrals to your service? And if so, who basically is landed with any questions of liability and certainly questions of responsibility and accountability? And so locally that's been worked out so far, but I think there's something to do there in working out what's the whole structure. And I suppose a final plea would be for it's well and good, and indeed very encouraging to see, for example, Great Ormond Street has allocation of funding. I think basically resources is one of the big elephants in the room, because this whole service is reliant on volunteers. Some clinicians in some settings have a day or half a day put aside. Great. What about the rest of the committee who are lay in various senses? They're academics, they're perhaps lawyers, they are patient representatives. There's no allowance for them and no compensation indeed for them either. And they're the ones, this links them back to data sharing and the like. That's where you definitely need some sort of honorary contract at a minimum, some sort of confidentiality agreement, and so on and so forth. So horrible to bring up the money thing, but I think it is, unfortunately, the elephant in the room.
Yeah. I think Richard's right.
It's an interesting one, because I think our survey indicates that there has been greater administrative support during the pandemic. There's a question as to whether that will remain, or whether indeed all those ethics committees that have been set up in the pandemic will remain. Yeah. And there's also a question of going beyond the administrative support to allocated hours, etc. Maybe that's not enough, but certainly I think it is the minimum that is needed for things to do well. There was a paper out a while ago suggesting that the bureaucracy in setting it up and the lack of administrative support really was preventative in setting up local ethics committees. So certainly an interesting area that we need to look at more. So we've got a couple more hands up. I'm sorry, I don't know which order they went up in, so I'll start with Jonathan because he's first on my screen. I hope that's okay.
Thank you. I think that was the order as well, but Dominic and I will arm wrestle later. I just want to draw a parallel with research ethics committees. So a lot of those things were also true of research ethics committees for many years, and research ethics committees then got centralised. And I think that plays in a bit to the discussion we were having this morning about national and local guidance. So there's a strong view amongst some ethicists that the centralisation of ethics committee was designed to create consistency, and that consistency was designed to favour the pharmaceutical companies. So I think that there's some work to be done in trying to tease out what the similarities and differences are. And as part of that work, there are perennial challenges that we have in research ethics. I should declare a former interest as a former chair of the Health Research Authority here in what we mean by consistency. the system we created there is you only have to go to one place to get a decision, which makes sense if the decision is going to be the same decision wherever you go. But we also know that it's not the case that that's true, although we can provide some controls, and we used to do work on sending the same issues to multiple ethics committees to try and tease out what the variations were. But you can get some process consistency, but you can't really drive consistency of outcome. But of course, if you did drive consistency of outcome, you would absolutely fall foul of the point that Joe makes, that no one would risk coming to the clinical ethics committee where they didn't trust that they would get an outcome, at least that they would respect. So I wonder whether one of the pieces of work out of this is trying to work out when it's appropriate to compare to the History Research Ethics Committee and when it isn't. Thanks.
Go ahead, Dominic. Sorry.
Yes, I mean, I was going to reflect without knowing what the answer is about what the impact of the pandemic is going to be on the provision of clinical ethics across the UK. There was a moment early on where it looked like ethics had kind of come of age. It was like there was suddenly all this discussion, this flurry of enthusiasm, of interest. All these trusts around the country were busy suddenly realizing, oh my God, we need clinical ethics. We've ignored it for all this time, but now we desperately need it. And just as I've become increasingly bitter and cynical as the pandemic has gone on about the impact or lack of impact of ethics on public policy, I've become increasingly skeptical about that this will last, this moment of enthusiasm. But I suspect that it'll depend hugely on what has happened and how much value individual trusts have seen in what ethics committees have done. I mean, the work by Suzi and her group sounds extraordinary, and sounds like that it has become a real proof of concept for a regional ethics committee. I hope, looking at Jonathan on the camera, that what we've done locally will continue to be supported. It certainly has been so far. But I don't think I suspect it's not going to continue everywhere. And of course, again, the elephant in the room resource question is going to come in the context of 5-10 years of the NHS being under extraordinary pressure, and ethics being seen as very much a luxury that we sadly can't afford.
I think there's a real question mark over the future. I mean, even in a place like Devon, given all that integrated care boards are going to be responsible for and the pressures they will be under, I have decided I don't want to go forward being the chair of the Devon system, at least the chair of the integrated care board. And it will be really interesting to see whether it survives that. I don't know. We are one of the things we've decided we're going to do is review our impact in the next few months. And since Jonathan's question about whether it is better to have non-treating clinicians involved in a decision, clinical decision, which is included in our guidance as a good thing to have, at least people sharing that decision. And we will test that, I think, Jonathan, and see what the impact of that's been.
I don't know the answer to it, Susi. I do think it's a question it would be nice to know the answer on, so perhaps you could share it when you find out.
Joe, go ahead.
So, having done this for a reasonable time, the only reason trusts had to have a clinical ethics committee was it used to be a positive influence on the clinical negligence schemes for trusts. So you'd end up paying less money for your insurance every year. Unless clinical ethics shows value to hospitals in a system where we are massively behind in terms of the requirement to do 1 million hip replacements, whatever it is. Ethics is going to wither on the vine, however much it's thought to be a good thing during the pandemic. It has to show usefulness to a board, to people, to people who are making decisions. And I think to go and ask for funding now is really tough. I mean, unless you kind of say, look, we had a good pandemic, generally, it wasn't bad. What do you think about having more support going forward? I suspect half the exec teams will say, well, that was great when we had to make really difficult decisions about not enough ventilators, too many people. But what do you do normally for us? Unless we have a much better answer to that, and I think we've done reasonably well, and our hospitals still come back and say, can you show us what you've done? How are you going to improve? Where's the external review? All this kind of process. And I think that falls on the people here. I mean, to set that up in terms of governance and structure, it has to be much more professional. And Jonathan's point about research ethics and what can be taken from research ethics versus what isn't suitable, it is a really important one, because you don't have a choice. If I want to do some research on people, I've got to go and talk to the HRA Research Ethics Committee. I haven't got a choice. It's mandatory. And here's the point. So unless we have somebody says that clinical ethics is so useful, it ought to be mandatory in these situations, I think it will continue to be a Cinderella service. I'm sorry to be a bit negative about that. But unless you can develop and show and grow, I can't see that most hospitals are going to start investing in this unless it becomes some sort of mandatory system that's required. As in the US, you can't have a hospital without ethics in the US. So unless we have something like that, where it's valued and shows its value, I think we are going to be in a difficult situation.
Okay, Susie, do you want to come back on that?
Just reflect that when we're thinking about how, whether we want to kind of protect this activity for the future, and if so, how, I would make a plea that we think also about primary care and social care, because if we're trying to integrate the whole thing, one of the things we surely have realised through COVID is that not all the difficult stuff happens in acute trust. A lot is going on in other care settings, and surfacing those issues and the moral distress there is just as important, I think.
Okay, thank you. And Jonathan?
I think there's some quite interesting questions in the chat we should get back to, but I just wanted to make a couple of observations about Joe's point. The challenge of using the REC model of mandatory gatekeeping is we then have to define what an ethical issue is, and we'll find that really difficult without making every decision that you make an ethical issue. So that's going to be quite tricky. I think that makes the sort of CQ, Care Quality Commission, well-led domain sort of approach to it more interesting, because you're saying that any well-organized organization would have capacity to support these things. So you're not necessarily defining the things that go there, but there must be something to go. That then will create a major challenge for smaller organizations, and particularly for primary care, where you'll create a regulatory burden that will be resented, but rather than welcomed by those bodies. I don't see a serious worry about Great Ormond Street or Oxford University Hospitals stopping the ethics approach, because they're constantly pushing the boundaries in terms of innovation, and they need that cover, and they know. But I do see the problem in the sort of mainstream everyday questions. And as a number of people, including Dom, pointed out, these questions we've been grappling with as if they're new in COVID are what people do every day on paediatric intensive care units or adult intensive care units. It's normal business, not something unusual for them. So we need to be really careful not to create something that just looks like a burden, because that plays into the hands of the people who say this doesn't really protect anybody's interests other than lawyers and ethicists, and that would be an unfortunate place for us to go.
Thank you very much. And Richard, I think you wanted to come in as well.
Yeah, if it's okay. I mean, this could take quite a long time, so I'll try and keep it brief. But it's about this overarching question here about, well, as Joe put it, first of all, you need to work out what are the goals and aims of a service, and then what shape does it take? And then it's really about evaluation. It seems to be the latter points is concerned with that. And this is just a couple of observations, really, around about 7 points, which you could try and attempt to measure, evaluate. So I'll try and race through the list as quickly as I can. One is something around supporting clinical decision-making itself, just simply being supportive of clinical decision-making that's appropriate. You could run some sort of audit of existing services. I know we've had some of those in the past. There's something about reinforcing or demonstrating the organization has an ethical culture. In a way, how many reports do we need of various scandals, controversies, and so on that suggest there's some failings ethically in there? How many of those do we need before we actually take action or formalize? Number 3, something about fostering trust. Briefly to note, a small part, I should say, of a team in Bristol that ran a survey last year at 2 time points of public trust in, the headline was COVID science and COVID scientists. And the headline was pretty good. There seemed to be quite high levels of trust, but it was reducing at the second point in time. So there's something in there. And on that, I would draw people's attention to a really interesting report led by Deborah Bowman that was published last week, Ethics in Extraordinary Times, some interesting lessons around trust. So I just query if there's a way of demonstrating or enhancing trust and even trustworthiness through having a service. Number 4, patient well-being and satisfaction. Again, must be ways of measuring that linked to the service. Staff well-being, moral distress, great deal of work there, as Joe's pointed out, Anne McNiven and colleagues in Great Ormond Street. And then some of the horrible things in life, reducing and removing conflict. So are we receiving fewer complaints and indeed fewer legal proceedings and the like? Now that seems like a harsh measure that might actually take you back to questions about goals and aims. Is that something we're aiming to do? Because it could be quite a different service that's indicated if so. But those are 7 or so ways that we could start to crack this evaluation nut. But I would say there was a Cochrane review a couple of years ago that basically the take-home message I took from that was there is insufficient research on working out how we evaluate a service internationally, at least in the setting they looked at. That was led by Jan Schildman and colleagues in Germany. So I think there's work to be done there by the academics at least, but probably audits as well elsewhere in the system.
Okay, thank you very much. So we haven't got very long left now. We've only got 5 minutes or so. So I just want to turn to a question that Ron Gillen has raised about the ethical principles that underlie the advice that we give. And in particular, he's interested in the reception of the 4 principles and how they've been used by ethics committees when producing guidance. I wondered if anybody had any comments on that, about what principles they used, why they used them, whether the 4 principles in particular were useful when setting out guidance.
I'm going to take the 5th Amendment, knowing that Ra's on the line.
I'll do the opposite strategy. I'll admit to Ra that we don't use them, but that won't be a surprise to him. I think going back to something that Susi commented on, which wasn't quite what I intended to say this morning about the usefulness of capacity to benefit. My point I thought I was trying to make was not that it wasn't useful, is that we couldn't agree on it, and that we had a number of different arguments about what was the right approach to triage. The reason why I've not found the 4 principles particularly useful in these contexts is that the debates that the committees I've been on have find themselves doing is in the bits of the differential justifications for the 4 principles. So as I understand it, one of the claims that principlism makes is that you don't have to resolve those deeper arguments about the foundations of ethics to have something workable. And the 4 principles give you an ability to have a conversation in most circumstances without having to fall back on those foundations. And I'll hold there because Ra can't quite answer that, but I know he'll be able to tell me later on. What I found is in these very novel areas, people tend not to fall back on the 4 principles, but they tend to fall back on the foundations that may have made them adopt those principles for general use. And that's why we've not really found ourselves discussing in those terms. On the other hand, very strongly justice comes through in the distribution principles, and aspects of autonomy come through, and it's very possible to describe quite a lot of the things that made their way into the guidelines in terms of the, depending on which side of the coin it is, the attempt to do good, beneficence, no, or the desire not to cause harm, non-maleficence. So it's not that we're in a different territory, but it hasn't been the currency of debate in my experience.
I would say the same for us.
Okay, thank you. Okay, so I just want to ask one question of my own, and that relates to some of the historical criticisms of clinical ethics committees, that when they meet regularly, let's say monthly or bi-monthly, they can't always respond to immediate issues. And Joe, you've mentioned the importance of bedside support in the pandemic. I wondered is that something new that you've done that's pandemic related, Or is it something that you've always done within the committee? And if it is new, is it something that you want to keep going? And do you think it could be rolled out more broadly?
So we set it up in that evolution to a paediatric bioethics centre from our old committee. So we've been doing that more and more since 2014, and almost all our ethics consultations are now with children and families bedside in a room afterwards with a group of us talking with the clinical teams and the parent families. So I think that's a normal process. It preceded the pandemic. The thing that was new for us in the pandemic, and I was very, very old at this, I was a real block, Dave will let you all know, I'm not lying here, on video conference consultations. I just thought it'd be terrible. I didn't think anyone would be able to speak freely. I was very worried about what it would mean for children and families. And actually, I've been completely converted. So the ability to have a rapid ethics consultation with a family that are at home, a parent at home, parent by the bedside because of social distancing, involving the child if necessary, has become much easier. And we're really lucky. Mariana, who's currently on it, has been amazing at fixing, even with children who've come in acutely with the odd serious COVID. And that worked remarkably well. So I think in terms of the right thing is to bring ethics out of the boardroom. You can't wait for a meeting in 6 weeks' time. I think that's crazy. Or even the not so rapid need for clinical decision making. Dominic and I, as the clinicians on here, will tell you that every decision we make is really important. It has to be dealt with fairly quickly, even if it doesn't, because that's the nature of clinicians. We don't do come and see me in 6 weeks about this sort of stuff. If it's ethical concern enough to come to an ethics committee, you really want it to be happening fairly soon, not always the same day, of course. But most of the decisions around a pandemic situation are quick, rapid in terms of, do we need to carry on doing this sort of stuff? If you're going to wait 6 weeks, then the question either doesn't need to be asked or it'll be a different question by that stage. So we've done this for some time. I don't see any reason we will change from this system. Our feedback from those who consulted us before and after is they much prefer this system as clinicians. The family feedback of having an ethics person come and talk to them, prepare them for the meeting, either by Zoom or by the bedside, and then be involved in the meeting is almost universally positive, with a couple of notable exceptions I talked about. And actually our big surprise was having children and families in the room. Children's not that common because they're often very sick. But that hasn't inhibited the clinicians. So we try and give space for each of those groups. So clinicians have a period of the meeting when the family aren't there, then the family will come along. And occasionally we thought that was a real problem. And probably before Dave's time, we've had times when the family become quite upset, and we have ways of dealing with that. But actually none of those families who've become very upset have regretted being part of the process when we seek feedback from them. So the main, just for people's interest, the main problems we've had from families, one is the clinical decision is something they don't agree with afterwards, so the ethics team haven't helped me change that. Or there are just too many people in the room, and that's something we listen to from working with parents and families. And it's difficult when you have these multi-system complex children, when they have 8 different clinical teams who all feel they're very important in the ethics. And that was really challenging before COVID. It's really interesting because you don't see the second student. So official stuff from children and families are that they don't mind having so many people on a video conference. It was coming into a room. And we still try and restrict it to only, maybe 10 people at most. Anyway, that's a long answer to, we did it before COVID. We don't see any need to change. It works very well.
Marvellous. Thank you very much. And I think we're going to have to draw things to a close because it is now 4 o'clock. So thank you so much to our speakers and our panellists for a really rich discussion, which is going to help Dave and I an awful lot in thinking about the questions that have emerged from the webinars. And I think some of the themes of ethical preparedness, of central versus local, of procedural versus outcome-based, and themes about legitimacy and authority cut very clearly across both the sessions that we've had today. Dave, do you want to add anything before we sign off?
Now, Mandy Rice Davis is the answer. And there's a very good reason why some people can't remember this.
Well done, Dave.
Thank you. Thanks for everyone.
Okay. Well, thank you very much, everybody, and goodbye.